Hello, hi guys. I think you're able to hear now. Yeah, that's why I'm here. The session is starting today. Okay. Of course, yes. People have joined already. If you can hear and see me, you can let me know. Okay. Just hold on. Okay, thank you. Okay, welcome back. So what I was thinking is like because we didn't do the live sessions for quite some time, and the premium sessions are also online, which we'll be doing in a short while. What I was trying to do is the fact that we'll be doing live sessions regularly hereafter, probably every Wednesdays, whenever I intimate, maybe after 6 o'clock, because 6 is the time when where I used to complete my practice on Wednesdays, especially. So Wednesday, we might be having some few sessions like this, maybe two sessions. Maybe you can keep one session from probably like 2 hours, maybe from 7 to 9 or 8 to 10, like that. And after that, a second session maybe from 10 to 12 or 10:30 to 12:30, like that. So I'm probably thinking of two sessions. Maybe we'll be discussing something or the other. Maybe even if the portions are complete, let us try discuss something or the other every time. On Wednesdays, we might keep this sort of discussions probably. That's what I was thinking about. And apart from that, your premium videos, we are trying to do some things. So like our studio setup is ready. Even I am a little okay right now. So premium sessions might start anytime this week. With this, I think we can probably start our discussion as well. Yeah, clinical cardio in these sessions we'll try, like in the sessions, like I'm probably taking a sort of a sabbatical now. So let me try doing some clinical sessions also if possible. Nevertheless, let us finish off the mock things. Like I think only a little bit of hepatology and your GITs left. So like malabsorption and all this stuff. So let me finish off those things first in the first place. Okay. Let us start the session. I think everything is already, the audio visuals are good. So I think today we'll be starting with metabolic liver disease. I think two things in hepatology which I have not completed is the metabolic liver disease, and second is going to be the hepatocellular cancer. So these are the two things, and some of the liver tumors is what is we didn't complete in the previous session. So that's what we're going to do in these sessions. So first, let us start with metabolic liver diseases. So when we are discussing about metabolic liver disease, there are three liver diseases which we need to know. So one is going to be, of course, the Wilson's disease, and second one is going to be the hemochromatosis, especially the hereditary hemochromatosis part. And the third one, of course, is going to be the alpha antitrypsin deficiency. These are three things which we are going to discuss, by the way, in this particular metabolic liver disease section. The first metabolic liver disease that is very important for exams is, of course, going to be the Wilson disease. That is the first thing we're going to discuss. Wilson disease. As far as Wilson disease is concerned, the age of onset of Wilson disease. We have seen Wilson disease happening in around 30, 35 years also, but nevertheless, most often the age group will be around 12 to 15 years. That is the time where the disease starts manifesting. But if you really want to know the age, we can write most commonly in the age group of probably around 12 to 20 years. That is where you diagnose most of the Wilson disease cases, but it can be diagnosed even up to 35 years. And the youngest Wilson patient on record is around 5-6 years. So which means the age group is a little variable, but this is the most common age group where you're going to diagnose Wilson disease. And we know what is the pathophysiology behind development of Wilson disease. It's a genetic disease, of course, and it's an autosomal recessive disease. It's due to a problem in a gene called as ATP7B gene in chromosome number 13. So this is a chromosome that is asked multiple times in exam. I don't know why. Probably they are obsessed with this chromosome. But still, you can remember that. I used to remember this as a unlucky disease. So, and 13 is an unlucky number. So 13 we can regard as an unlucky chromosome. That's why Wilson disease happens if the patient is unlucky. So that's how I used to remember. So as far as ATP7B is concerned, let us see what is the function of ATP7B. Before that, we need to know the pathophysiology of development of Wilson disease, how the Wilson disease is going to be developed. As far as Wilson disease is concerned, it's a problem of copper. We know that. Like first when you take a dietary copper, so when copper comes in the diet, so this dietary copper is basically absorbed into the circulation by a very important transporter. You know what is a transporter? Can anyone tell what is a transporter that is responsible for absorption of dietary copper? Maybe you can write as Cu2 plus. No, it's not DMT1. DMT1 is also important, but what I'm asking is something different. So what is the most important? I mean, DMT1 is also important, but DMT1 is not the only thing. But we are talking about something else here. So we are talking about something called ATP7A. This is what I want. So ATP7A is a very, very important, transporter that is important in absorption of this dietary copper. So whenever there is a problem in ATP7A, so you're going to result in a disease, you know that. So that is what we refer to as a Menkes disease or Menkes kinky hair syndrome. That's what you call it as. It has a series of findings which are not going to discuss right now. So that is due to problem in ATP7A, not ATP7B. So that's why it's important, because ATP7B will result in Wilson disease, but ATP7A defect will usually result in something called as Menkes disease, which is due to copper deficiency because the patient cannot absorb the dietary copper. And once this copper is absorbed into the circulation, it's going to enter the portal circulation, of course. So it's going to enter the portal circulation. So we can write as portal copper. So once in this portal circulation, the next destiny is going to be the liver, of course. We know that. So what happens in the liver is going to be the next part. So this is in the hepatocyte in the liver. So what happens in the liver? So whatever copper that enters into the hepatocyte will be actually pushed into a protein called as apoceruloplasmin. Initially, this protein without copper is what we refer to as apoceruloplasmin. And once you load copper into the apoceruloplasmin, which means usually you load up to 6 atoms of copper. Trust me, it is 6 typically. 6 atoms of copper is what is going to get loaded into the apoceruloplasmin. Once a copper is loaded into the apoceruloplasmin, it becomes a mature protein called as ceruloplasmin. And of course, the important protein that is, responsible for this loading of the copper into the apoceruloplasmin to become ceruloplasmin is what we refer to as ATP7B. So this is where it is very important. Of course, some of the copper will not be loaded into the apoceruloplasmin, and it will be of free copper within the hepatocyte, and it will be excreted in the bile, of course. In the bile, that will be excreted as free copper. And to excrete this free copper into the bile, once again, you need this ATP7B. It's not like ATP7B is important only for loading the copper into the apoceruloplasmin. ATP7B is also important for loading copper into the bile as well. Or pushing the copper, the redundant copper into the bile as well. Some of the copper, little copper, will go into the bile using ATP7B as well. So this ceruloplasmin is the one that is considered as a transport protein for copper in the circulation. So the problem, as far as the Wilson disease is concerned, we know the problem is in the ATP7B. So ATP7B is what is going to be the problem here. So once ATP7B is mutated and it is defective, you cannot load copper into the apoceruloplasmin, and there will be reduced formation of ceruloplasmin. So once there is reduced formation of ceruloplasmin, your total copper in the blood will decrease. Don't be fooled by that, but even though the free copper will increase, I'll discuss about that in some time. But at the same time, the total ceruloplasmin level will be decreased. So what are the effects of ATP7B defect? Let me write it down. So ATP7B defect, number one, the first effect is going to be reduced ceruloplasmin. Of course, there is no doubt about that. Because the reduced ceruloplasmin, the total serum copper will be reduced. Because ceruloplasmin is the chief carrier of copper in the serum, in the blood. So the total serum copper will, of course, be reduced without a doubt. And second thing, what's going to happen is you're going to have increased hepatocyte free copper, because without ATP7B, you cannot push this copper into the bile as well, and you cannot push this copper out of the hepatocyte using ceruloplasmin as well. And this apoceruloplasmin has a very short half-life, and it will be destroyed within the hepatocyte. So there is a lot of accumulation of free copper within the hepatocyte. So which means I can write there is increased free copper within the hepatocyte. And this is deleterious because copper also participates in Fenton's reaction like iron, and it's a very powerful oxidant as well, and it's going to cause a lot of free radical damage. So I can write there will be free radical damage because of increased hepatocyte copper, and that will result in the hepatocyte death. There will be hepatocyte necrosis, and there will be progressive death of the hepatocytes over a period of time. And this is going to result in something called as a progressive liver damage that can progress to cirrhosis. And depending on the damage, the patients can present asymptomatic, patient can present at cirrhosis, patient can present with a chronic liver disease, patient can even present with acute fulminant liver failure, that is acute liver failure as well. So the damage can be to any extent. So in general, the damage will be of progressive type. Usually they will present with a CLD or a cirrhosis. So that's how they present. But acute liver failure, that is fulminant liver failure, is also not a very uncommon entity. There are a lot of cases in the literature, and even I have seen 2 cases which the patients have presented with acute liver failure due to Wilson disease. So you have to take with a pinch of salt. They can present with any kind of presentation. So once the hepatocyte dies, so it doesn't only result in hepatocyte damage, that also is going to release the free copper into the circulation. It's going to release free copper into the circulation. So once this free copper gets released into the circulation, so there will be increased serum free copper. So the free copper levels will be actually increased. Remember, this is the irony here. The total serum copper will be actually reduced because ceruloplasmin is the chief carrier of copper in the blood. But the free copper levels will be increased because of the release of this free copper molecules without ceruloplasmin from the death of the hepatocytes. So that's point number 1. At the same time, this free copper, that is increased serum free copper or free copper in the circulation in excess, is definitely going to cause copper deposition in other tissues as well. Ceruloplasmin is the one that protects the deposition of copper into other organs. It is a transport protein which helps in just delivery of copper to particular areas where they need copper, but free copper is no good, and it's going to definitely result in deposition of copper in other tissues. This copper deposition will result in free radical damage again, so which means, for example, they can have organ deposition, and this free copper can also result in something called as hemolysis. hemolysis as well. So sometimes they can result in development of hemolysis. Especially hemolysis is very common in patients who are presenting with acute liver failure. But apart from that, hemolysis is uncommon in patients who are coming with cirrhosis or probably a chronic liver disease. But in patients who present with acute liver failure, hemolysis is one of the very, very important clues. One of the clues for diagnosing Wilson disease that is causing acute liver failure. And copper that is deposited in the organs, for example, in the eyes, it can deposit, especially in the cornea, that results in development of this Kayser-Fleischer rings, or in the CNS, central nervous system, it can deposit, especially in the basal ganglia. It can start depositing and it can produce neurodegeneration and chorea there and the movement disorders because they produce that characteristic wing beating tremors. So it's a neurodegenerative disorder as well. So these are the effects that are going to happen due to increased copper deposition in different organs. And in all these areas, they are going to participate in Fenton reaction and they're going to result in development of free radical mediated damage. So this is the wholesome pathophysiology of development of Wilson disease. Remember, once the serum copper, if the free serum copper is increased, even the urinary free copper will increase as well. The free urinary copper levels also will increase, which means the urinary copper or the total urinary copper also will increase because ceruloplasmin is not something that's going to get excreted in the urine. So in these patients with Wilson disease, the urinary copper will be high. That is because the free serum copper is very high, which will be filtered by the kidneys and excreted in the urine. So which is a very important diagnostic point. At the same time, when you come to the clinical features of Wilson disease, you can divide the clinical features into three presentations. So one is going to be the hepatic presentation, and second one is going to be the neurologic presentation, and third one is going to be, of course, the psychiatric presentation. So next thing is the first one is the hepatic presentation. Remember, it is highly variable, which I've told you. They can have an asymptomatic spectrum, which means incidentally you will find because of some altered LFTs, very rare but still possible, or they can present with chronic liver disease, or they can present with cirrhosis, completed cirrhosis as well, or they can present with acute fulminant liver failure, that is ALF as well, acute liver failure, or they can present with simple acute hepatitis without ALF as well. Acute hepatitis without ALF as well. But if you ask the common presentations, it's going to be CLD or cirrhosis. This is how they're going to present from the hepatic standpoint. ALF is rare, asymptomatic and acute hepatitis presentation is also quite rare. Not that common compared to the of CLD and cirrhosis presentation. And what they will be definitely asking you is what are the characteristic features of ALF due to Wilson disease? So what will be the characteristic features of acute liver failure due to Wilson? There is some characteristic markers in the form of enzymes or probably the ratios that we're going to see. Number one, if at all the ALF is happening due to Wilson disease, clearly you'll be having hemolytic anemia. And if I ask you whether it's a COMS positive or COMS negative hemolytic anemia, you're definitely going to answer it as a COMS negative hemolytic anemia because it's not an autoimmune hemolytic anemia. That is because of high copper that is released into circulation that is actually causing free radical damage and hemolysis. So it will be COMS negative. It's not autoimmune etiology. That's what the answer is. And typically the hemolytic anemia will be intravascular hemolysis, more of a intravascular hemolysis and not extravascular hemolysis. Clear? And because copper damages the red cell membrane heavily and it causes oxidative damage to the red cell membrane, that is the reason why hemolysis happens in this particular setting. And usually, whenever there is hepatitis and liver failure, there will be elevated alkaline, AST and ALT. The liver enzymes will be elevated. But remember, I think I've told you this point already. In ALF due to Wilson disease, AST levels will be more than ALT levels in the sense like AST ALT ratio will be, ALT AST ratio will be less than 1, or we can call it as OT-PT ratio. So because here the patient is having OT which is more than PT, OT-PT ratio will be more than 1. So very few conditions you'll have OT-PT ratio of more than 1. One example is alcohol, which I've discussed already. In alcoholic hepatitis, you'll have a OT-PT ratio of usually more than or equal to 2:1. That's called a de-Ritis ratio, which I've discussed already. A second example is in Wilson disease, where even in Wilson disease, the patients might have AST more than ALT. And number 3, you might be having very, very low alkaline phosphatase. This is something which I've described already in the earlier section. So very low alkaline phosphatase is a characteristic feature of Wilson disease, which means less than 40. And there is one ratio called as ALP to total bilirubin ratio. Because the ALP levels will be very low in acute liver failure due to Wilson disease and total bilirubin levels may be very high, this ratio is usually less than 4. So this is something that can be asked in exam. If at all the patient is suffering from ALF due to Wilson disease, very likely your ALP by total bilirubin ratio will be less than 4, which means ALP levels will be very low and bilirubin levels will be very high. So that is the reason why your ratio will be less than 4, and that is the reason. And fourth, not very important, but they might be having very low serum uric acid levels. The reason for this is unknown, but they might have a very low serum uric acid. So these are the characteristic features of ALF due to Wilson disease. In that, I believe that this point, and this point is going to be the most important. If at all the most important point, I will go for the hemolytic anemia due to due to Wilson disease, and that's going to be the most important exam question as well. And apart from that, if you go to the neurological picture, because most of the copper deposition happens in the basal ganglia and probably somewhere in the cerebellum, you're going to have a lot of extrapyramidal and cerebellar features. So which means the most important typical features will be extrapyramidal features. As far as extrapyramidal features is concerned, the most common is going to be the dystonias as opposed to the tremors that are very commonly studied in undergraduation. Dystonia is going to be the most common picture. Then you might get ataxia, then you can get tremors. Usually tremors will be mild tremors only, but sometimes you can get this kind of flinching tremors, like we call it as wing beating tremors. That's also possible in Wilson, even though wing beating tremors is a classical word that is correlated with Wilson disease, but most of the times you don't really get that kind of like very explosive tremors. It will be very mild tremors only in patients with Wilson disease. And they can develop bradykinesia and Parkinsonism because of the deposition in the basal ganglia, of course, and they can develop this drooling of saliva as well. The most important point is the fact that there won't be any sensory changes, and there will be absolutely only motor problems. Bladder bowel incontinence will not be there, and there won't be any associated sensory problems as well. And if you take a CT or MRI, you can see hyperintensity in the basal ganglia region. Remember, in MRI, if you ask which kind of MRI, it's T1 or T2 weighted, and T2 weighted MRI, of course. In T2 weighted MRI, you might see a hyperintensity in the basal ganglia, and at the same time in CT imaging also you might see hyperintensity in the basal ganglia. But apart from that, there is not much you're going to see in CT or MRI. Coming to the psychiatric problems, because many of them are school-going children, like 10 years, 12 years. So that is the time where you're going to diagnose Wilson disease. The first thing you will usually notice poor performance in the schools or probably in the colleges if they are joined early. So in that setting, you might be having that low performance state. And some children and adolescent people can go for depression, irritability, and they might develop a labile mood. They can develop frank psychosis as well. At the same time, they'll be having dysthymia, and even the psychosis can be of bipolar depressive psychosis as well. It could be any form of psychosis, but nevertheless, declined school performance is one of the classic features of Wilson disease, and it can be picked up at early stages if you are knowing this differential diagnosis, which is also very important. And apart from that, you have some extra presentations as well, extra features of Wilson disease. For example, you have the classic KF ring, so which is an ocular deposition of copper. Especially, the copper is having affinity towards the Descemet's membrane in the cornea. So Wilson disease can have this. Patients with Wilson disease can have this KF rings. So it's a brownish ring due to deposition of copper in the Descemet's membrane in the cornea. And remember, KF ring, the intensity of the KF ring usually is proportional to the CNS copper. That's very, very important. It's not the hepatic copper that's going to be demonstrated in the KF ring. It's the CNS copper. Amount of CNS copper is going to be directly reflected in the KF ring. So that's why they call eyes are the window to your brain. So like that, if you see the intensity of the KF ring, the more the intensity of the KF ring is, more is going to be the CNS copper. Remember, literally all patients with CNS disease will have KF rings for sure, which means indirectly you can tell if the patient is having a KF ring, you can tell surely they will be having CNS disease. The association between KF ring and CNS disease is approximately 98%. Practically speaking, it's 100%, but theoretically speaking, it's 98%, which means each and every individual you see with Wilson disease, if they have a KF ring, of course, they will definitely have a CNS disease as well. So typically, KF ring is best seen in the slit lamp examination. You should not see with the naked eyes. Naked eyes you might see, but slit lamp is one of the best ways to see this KF ring. At the same time, it disappears with treatment as well. So this is something I've been telling in the previous lectures as well, even in some of my unacademic lectures as well. And that's the same question that's asked in the recent times as well. It disappears with treatment. Once you start treatment, this KF ring will disappear. So in the sense, like it can be used as, entity for following up a patient whether they respond to treatment or not. So it disappears with treatment over a period of time, but it takes a nice 3 to 5 years to disappear. It's not something that's going to disappear in a day or two or a month or two. It's going to take around 3 to 5 years to disappear. And second ocular thing is the fact that they can develop cataract, And you know what is the type of cataract that you're going to get in Wilson disease patient, that is going to be uh, sunflower type of cataract. So let me show you an image, by the way. Yeah, I think this is the image I wanted to show you. Yeah, got it. This is the image I want to show. So this is the example of KF rings. You can see a brownish ring that you're seeing here. So this is the KF ring basically, which is shown by the red arrow here. And of course, this is the typical sunflower cataract that you're seeing here. And this is the KF ring that is seen in the slit lamp examination as well. Maybe I can show here. This is the KF ring that is seen in slit lamp examination. Clear? And this is the typical sunflower cataract. And this is the KF ring that is seen in the naked eye. So this is a very important image as well. So there might be some few images that might be asked. And one more finding that you can see in the nails, which I want to show. So this kind of bluish discoloration of nails is a very important finding in Wilson disease as well. This is what we refer to as something called as azure lunule. AZURE. That's called azure lunule. Clear? Usually, again, this kind of bluish discoloration also disappears with treatment. In the sense, this can also be used as a marker for follow-up of treatment and therapy. And apart from that, ocular presentations, they can have renal presentations as well, which are quite rare. As I told you, any inborn errors of metabolism, I think we have discussed that in nephrology as well, can produce renal tubular acidosis, especially proximal RTA compared to the distal RTA. We have discussed this already. I've told you fancy conditions in proximal RTA produces Fanconi. We have discussed that already in nephrology section. Fancy means Fanconi in the sense like fancy conditions like inborn errors of metabolism, cystinuria, Wilson, all these are fancy conditions, so they can produce Fanconi and hence proximal renal tubular acidosis. And they can develop cardiomyopathy. Typically, any metabolic condition will produce restrictive or dilated. Very commonly, they'll produce restricted type of cardiomyopathy only. And patients with Wilson disease can experience infertility as well. So these are the usual key points that is important for exams. Then let us move on to the investigation. How to diagnose a Wilson disease, investigation-wise. As far as Wilson disease investigation is concerned, the most useless investigation is the serum copper, the free copper or total copper, whatever you do. So that is going to be the most useless investigation, which is never performed at all in the first place. The usual screening test that you're going to do is serum ceruloplasmin. This is the first test, or probably we can call it as a screening test of choice for Wilson disease patients. Usually the serum ceruloplasmin levels will be decreased. If you ask somebody, what is the normal levels, normally it is more than 20 milligrams per deciliter or 20 milligrams percentage. This is normal. If it's less than 20, probably you can think about Wilson disease in that perspective. But this is not a very good investigation, even though it's a screening test. The reason is because it can be normal in approximately. People with Wilson disease can be having a normal ceruloplasmin in approximately 10 to 25%. In the sense, like 10 to 25% of patients with Wilson disease can have a normal serum ceruloplasmin, that is the reason why it is not always reliable. Suppose the levels are less than 4, it confirms that the patient is having Wilson disease for sure. Levels of less than 4 will confirm for sure 100% the patient is having Wilson disease. Remember, it can be normal in 10 to 25%. But if the levels are less than 4, there is no doubt 100%. With that itself, you can make a diagnosis that the patient is having Wilson disease for sure. This is the utility of ceruloplasmin. Remember, ceruloplasmin is most often used as a screen test, which means it's one of the first tests that is done in patients who are suspected to have Wilson disease. And second important investigation is the slit lamp examination, because if you are able to find out the KF ring, then probably the patient might be suffering from Wilson disease. Remember, KF ring is not very, very specific for Wilson disease. In the sense, like almost, like if you see a KF ring with appropriate clinical features, it is equal to Wilson disease only. But KF ring is not 100% specific. In the sense, it can be seen in Wilson disease. At the same time, it can be seen in certain cholestatic conditions as well. Like any cholestatic condition, even extrahepatic or intrahepatic cholestasis like primary biliary cirrhosis can develop KF ring over a period of time. The reason for that is very, very simple. Come back to the pathophysiology. Remember, there is some amount of copper that is getting excreted in the bile. So if there is a cholestasis, the bile cannot flow properly, in the sense like this copper that is getting excreted into the bile cannot get excreted properly. So there will be increased accumulation of copper within the hepatocyte, and by the same mechanism they're going to release that excess copper, and by the same mechanism they can produce increased free copper in the serum, which can cause deposition in the cornea, and they can produce cave ring over a period of time. So one of the important differential diagnoses for cave ring, apart from Wilson disease, you need to know is the cholestatic disorders, which can produce cave rings as well. And apart from that, we do something called 24-hour urinary copper. 24-hour urinary copper. Of course, as I told you, in patients with Wilson disease, the free copper levels in the serum are high. So 24-hour urinary copper levels will be increased in patients with Wilson disease. Usually, if the levels are more than 100 microgram per day, in the sense like 24-hour urinary copper is more than 100 micrograms, this is considered to be diagnostic of Wilson disease, by the way. So number 4 is liver biopsy. Liver biopsy is considered to be the gold standard for Wilson disease, even though it has a lot of pitfalls, but liver biopsy is considered to be gold standard. Remember, the copper or the amount of copper per gram of dry weight of liver is going to be high in patients with Wilson disease, in the sense like typical values will be more than 250 microgram per gram of dry weight of liver. So this is after biopsy is what I'm telling. After biopsy, if you take the weight of the liver, that's called a dry weight once you fix and do. So if it's more than 250 microgram per gram of dry weight of liver, that's considered to be one of the gold standard findings of Wilson disease. But normal copper will be less than 35 microgram per gram of dry weight. That's the normal amount of copper in the liver. But if it's exceeding 250, then you can be almost sure that the patient is suffering from Wilson disease. But please understand, increased hepatic copper may not only happen in patients with Wilson disease, as I told you, in patients who are having cholestatic conditions also may have an increased hepatic copper. So that is why you need to be a little careful. So for cave ring as well as liver biopsy increased copper, one of the important differential diagnoses, cholestatic condition. So it's not absolutely specific, but still, when you consider appropriate clinical presentation and when you do investigations, increased copper is considered to be very, very specific for Wilson disease diagnosis. But if you do an appropriate clinical settings, if you just ask whether it is specific or not, actually answer is not 100%. But when you do an appropriate clinical setting, the child is coming with neuropsychiatric manifestation and the child is coming with hepatitis, then in that setting, if you see increased copper, of course, I'll be diagnosing Wilson disease only. And next is the genetic testing, which also has a role to some extent. Here we are going to find out the ATP7B mutations in chromosome number 13. So which is almost considered to be the best way of diagnosing Wilson disease. Remember, but this is a little tough. This ATP7B gene defect testing is not available in all the centers. So you can, you can use this genetic testing if at all, if your liver biopsy is not conclusive, plus there is a strong suspicion of Wilson disease. If a liver biopsy is not suggestive of Wilson, in the sense like it's having a very confusing picture. Less than 35 is normal, more than 250 is definitely diagnostic of Wilson. But if it's in the range of 50 to 250, plus if you have a strong suspicion of Wilson disease, then in that setting you can go for ATP7B gene testing. Otherwise, it's generally not recommended. Most of the times you can diagnose based on clinical criteria and features, and as well as the other investigations. And serum copper, as I told you, is one of the most useless investigations. Never ever do the serum copper in reality. So where we know that free copper will be definitely increased, but total copper in the serum will be definitely decreased because of poor availability of ceruloplasmin. Clear? But this is very, very unreliable investigation. It's considered as the most unreliable investigation. So don't do this in the first place. And how to evaluate as an algorithmic basis in a patient who is suspected to have Wilson disease. First thing, what you're going to do is serum ceruloplasmin. Any patient who is suspected to have Wilson disease, you do serum ceruloplasmin and slit lamp examination by an ophthalmologist. Plus, you are also going to do a 24-hour urinary copper. All these things to be done at once, usually. First, I'm going to see the ceruloplasmin value. Based on that, I'm going to segregate all these things. So first, see the ceruloplasmin. If the ceruloplasmin levels are low, there is a strong suspicion of Wilson. Ceruloplasmin levels are not high really. So normal values are more than 20. So I can call it as normal. Less than 20 means I can call it as low. So next step is to look for the KF ring, whether the KF ring is there or not. So the KF ring is present or KF ring is absent. whatever, no matter what, next step is to look for the urinary copper. So if the urinary copper is going to be high, that is more than 100, so this makes a diagnosis, which means if the celloplasmin is low, KF ring is positive, urinary copper is increased. So what else you need to make it? To rule out Wilson disease, it's definitely Wilson disease for sure. The urinary copper is low. So this is a confusing situation, which means you don't really see a KF ring, but celloplasmin levels are low. But at the same time, urinary copper levels are also not up to the mark. So in this setting, only because of low celloplasmin and you have some clinical features that are suggestive of Wilson, in that setting, best is to go for liver biopsy. If the liver biopsy is also not suggestive, in the sense like if it's in the range of 50 to 120, 250 microgram per gram, then you can probably go for genetic testing. Otherwise, it's not required. So liver biopsy is suggestive, then you can finish it off. That's enough. So liver biopsy is also not suggestive and very confusing, but clinical features are very clear and correlating with Wilson disease. Then you can go for genetic testing. So if the serum celloplasmin is normal, then of course I'm going to see the KF ring. So if the KF ring is present, then remember here the celloplasmin is normal, but there is a KF ring. So in this setting, it's better to go for liver biopsy or genetic testing. So remember, genetic testing is done only if the liver biopsy is also indeterminate, but liver biopsy will give you the answer most of the times, because this is also another confused situation where celloplasmin is normal and KF ring is present. So this is little contradictory. The KF ring is absent in the first place. Then final take home point is, because we have done all these three things together, then you have to look at the urinary copper reports. If the urinary copper is high, then I'll be going for genetic testing versus liver biopsy. This is what I'll be doing if the urinary copper levels are high, because it's another confusing situation. If the urinary copper levels are low, diagnosis excluded, which means that the patient is not suffering from Wilson disease, which means the patient is having normal celloplasmin, no KF ring, low urinary copper, less than 100. So you can clearly exclude the diagnosis in this particular setting. So which means the only way where you can truly make a diagnosis, low celloplasmin, positive KF ring and a high urinary copper. If there is, or if can truly exclude the diagnosis when the patient is having a normal celloplasmin, no KF ring and low urinary copper, because these three investigations will be usually done in tandem, not like as a step-by-step basis. So when all three are negative, then you can exclude. When all three are positive, you can make a diagnosis there itself. Any indeterminate findings, like one is positive, other is negative, then in that setting, you can either go for a liver biopsy versus a genetic test. And this is the final take-home point. So this is the, final take-home message from this particular algorithm, which I have told you. So then we have some diagnostic criteria as well. So the names is what they will be asking you. There is something called Leipzig meeting criteria. So in the Leipzig meeting, they made a diagnostic criteria, which happened in 2001. Basically, it's a very old one. Remember, Leipzig meeting also proposed a diagnostic criteria for Menkes disease as well. The Leipzig meeting did not only propose a diagnostic criteria for like Wilson disease, they also have proposed a diagnostic criteria for Menkes disease as well. Based on the Leipzig meeting criteria, you have some parameters. If the score is more than or equal to 4, then your diagnosis of Wilson disease is supposed to be likely. And if the score is 3, then it is probable diagnosis, not, you need to do other investigations. If it is less than or equal to 2, then Wilson disease is considered to be unlikely. So according to this meeting criteria, if the score is more than 4, then you can probably think about Wilson disease. Otherwise, it is excluded basically. And for prognostication, you have a score as well. So that is what we refer to as a Nasser index or Nasser score. This is for prognostication basically. You have three things basically as far as the Nasser score is concerned. So generally, I tend to call it as ATP score. So why I generally call it, why I keep a mnemonic of ATP is because Wilson disease is due to deficiency of ATP7B or due to defect of ATP7B. So if I put the same mnemonic, it will be easier for you to understand. That's why. So A stands for AST, T stands for total bilirubin, and P stands for prothrombin time. So this will be a very easy mnemonic for you because this is something that is attached to Wilson disease itself. So AST, total bilirubin, and prothrombin time. So these are the three variables that you have to know to calculate Nasser score. So for Nasser score, the total score will be of, ranging from 0 to 12 in the first place. So if the score is in the range of 0 to 6 first, this is considered to be a low risk patient and the prognosis is generally going to be good And because of that, we can manage these patients just medically itself. We don't need any liver transplantation. So if it is 7 to 9, these patients are judged clinically. These are indeterminate patients, intermediate prognostic patients. So either you can go for medical management or you can go for a liver transplantation. It's like a child book score only if you come back to that. So if the score is 10 to 12 or more than equal to 10, so these patients are going to have a very poor prognosis. So it's better that these patients are going to go for liver transplantation. So the best candidates for liver transplantation is a score of 10 to 12, high risk patients. So intermediate group patients, either medical or transplant, and it has to be judged clinically. Low risk patients, those are having good prognosis, you can straight away start with medical treatment. That alone is going to be more than enough. And now I'm going to put another slide and you're going to tell what is the stain that is used here. So I'm going to tell that this patient is basically suffering from Wilson disease. Okay, let me show you this. So this is a patient who's suffering from Wilson disease, and this is the hepatic copper that's shown with the arrows, that red color things. What you see here is the hepatic copper that we are seeing here. So what is the stain that is used? So staining copper here. Any idea? What is the stain that is used? Okay, not alizarin. That's not a common stain used in reality. Stain that is used here is rhodamine. One of the important copper stains. I mean, that is used in my hospital as well. So this is the rhodamine stain that for staining copper. So, and it stains this kind of reddish pink color. So that's how the copper is stained. And you can even quantify copper because of, I mean, based on certain pathological algorithms are there. So rhodamine is the stain that is used here, that is showing accumulation of copper within the cytoplasm of the hepatocytes. And let us come back to the treatment. I mean, usually whenever I discuss about the treatment, I discuss on the ASLD guidelines. So that is American Society of Liver Disease. So ASLD is the one that is, there are many societies, as I told you. You have ASLD, you have APASL, you have then ESL is there. So many societies are there based on which population they encounter. So in India, we have APASL guidelines. So that is the Asia Pacific Society of Liver Disease. Similarly, you have American Society also, that is ASLD. Then we have ESL also. But Harrison, most of the time, any standard textbooks will give the ASLD guidelines only. But nevertheless, the treatment is going to be the same. The crux is going to be the same. There will be small changes here and there depending on which population they encounter. But nevertheless, so how we are going to treat. So you can divide into two groups of population. One is going to be asymptomatic group and second is going to be the symptomatic group. As far as asymptomatic group is concerned, we can split into two: initial management and the maintenance therapy. Maintenance therapy. So maintenance therapy, whatever may be the fact, whether it is symptomatic patient or asymptomatic patient, doesn't matter. The maintenance therapy is going to be the same. Clear? Okay. The maintenance therapy is going to be the same. That is going to be either zinc or probably a low dose chelating agent. Low dose chelation. That's going to be the maintenance therapy. Remember, zinc is best known for maintenance therapy, but zinc as a sole therapy is absolute nonsense. We are not going to use zinc as a sole therapy because many times I don't know where it's been mentioned, but some students have asked me the question that zinc is the treatment of choice for Wilson disease. Actually, no. If you know the mechanism of action of zinc and how it works, you'll be knowing that. So chelating agents are the ones that are going to remove the copper that is deposited in the organs. Zinc is just going to reduce the dietary absorption of copper. In the sense, we know that copper's main source is going to be the dietary copper. So this copper is actually coming from the intestine only. So which means to dietary absorption of copper. Zinc actually prevents the dietary absorption of copper. In the sense zinc is also Zn2+ and copper is also Cu2+. And because both are divalent and they compete with each other. So when you give excess zinc, the amount of copper absorption will be actually quite less. So that is the basic idea, which means the main mechanism of action of zinc is to reduce the dietary absorption of copper. So what about the copper that is already deposited in the organs and that's going to cause damage, like neurological damage or liver damage? That cannot be removed by zinc. So in the sense, like a patient who's having symptoms or any patient for that matters, I generally don't like giving zinc alone as a standalone therapy, because the copper that is already deposited has to be removed, and that can be done only by proper chelative therapy. So remember, the patient is asymptomatic, then you have options in this particular setting. So which means the patient is coming incidental presentation, or probably the patient is not having any symptoms at all. Then in this setting, you can try two things. So first line, maybe probably I can think about chelative therapy. And again, that's going to be the first line therapy. I'll tell you what are the chelative drugs that we have. Suppose if the patient is not tolerating or developing significant side effects due to chelative therapy, then second line option is going to be zinc. Zinc is a second line option, but still the first line option is going to be chelation. So you have to remove the copper that is deposited already. So for that, you need chelation for sure. Pain is symptomatic, then there is no doubt about that. There's only one therapy that you should give, whether they are tolerant or not doesn't matter. You need to give only chelation therapy, because the patient is already symptomatic and you have to remove the copper that is deposited in the organs already. So zinc is never a drug of choice. I don't know. And in the fact, like, even in pregnancy, you can give chelation. It's not like you should not give chelation in pregnancy. I don't know, because some students do ask, zinc is the treatment of choice in pregnancy. No, it's not like that. Zinc is safe in pregnancy. It's not that chelating agents are not safe in pregnancy. Even chelating agents are considered to be safe in patients with pregnancy. So what are the chelating options that we have? We have two drugs that we commonly use. One is going to be D-penicillamine, and second is going to be the trientine. So these are the two drugs that are available for chelation. In that, whatever is ideal you can use, but there is a little bit better and safe pharmacokinetics of trientine compared to the of D-penicillamine. So if you want to choose one drug, probably I would be preferring trientine. But both compared to the efficacy wise, both are going to be, of course, the same. Clear? So trientine may edge ahead a little bit. That is because it has a better side effect profile and little bit better pharmacokinetics and better safety profile compared to D-penicillamine. But apart from that, efficacy wise, both are almost going to be the same. So if you want to choose one drug among the two, I'll go for trientine. But both are efficacy wise the same, which I've told you already. And whether they can be given in pregnancy or not. Yes, chelative therapy can be given in pregnancy, but please understand, only the dose should be reduced by 30 to 50%. Whatever pre-pregnant doses that you are giving, you have to reduce the dosage by 30 to 50%. There are some animal models which tell some teratogenic effects, but overall, in general, the guidelines say it is considered to be safe in pregnancy, because the copper load in pregnancy is considered to be more dangerous compared to that of the teratogenic effects caused by these drugs. So definitely, you can give chelating agents if the patient is symptomatic even during pregnancy, but just the fact that the dose should be reduced by 30 to 50% in this particular setting. Okay, so now we discussed all these things. Remember, there is no standard drug of choice for Wilson disease. It's all about rational drug, which I've told you already multiple times. So don't tell any drug of choice, zinc or trientine or D-penicillamine. There are certain diseases where you cannot tell drug of choice. Wilson disease is such a disease. You have to use therapies in combination or in tandem with each other. This is the therapy for Wilson disease, and you have certain targets which you have not discussed. So what are the targets for treatment of these chelating agents? Remember, you should have increased urinary copper, in the sense like these chelating agents are going to basically remove the copper that is deposited in the organs, and they're going to excrete them in the urine. So in the sense like the urinary copper target is going to be somewhere around 200 to 500 microgram per day. This is initially. During initial chelation, you need to give the dose to achieve this amount of copper in the urine, 200 to 500 microgram per day. So urinary copper usually will, even though we set a range of 200 to 500, it might reach a value of more than 500 usually. But remember, by around 6 to 12 months of time, it becomes less than 200 microgram per day, which means initially it will be in the range of 200 to 500, or maybe more than 500 also sometimes. If the copper amount, deposit in the body is too much, then after 6 to 12 months, the amount of copper that is going to be excreted in the urine will come to less than 200 microgram per day. In the sense like your chelation has done a good job and has removed almost all the copper from the body. That's what it means. And second target, so this is the target number one, the urinary copper. Within 6 to 12 months, you have to achieve that less than 200 microgram per day range. And non-ceruloplasmin bound copper. Non-ceruloplasmin bound serum copper, in the sense like we're talking about a free serum copper, that should be less than 15 micrograms per deciliter. This is the second target. Even though for diagnosis, serum copper is not useful, maybe for establishing therapy, it might be useful. Then third is the normalization of LFT. Usually this will be achieved in 3 to 6 months time once again. So usually these are the targets that you need to achieve before stopping the chelation. But in general, the duration of chelation will be typically usually 6 months to 5 years. After which you will put the patients on maintenance therapy. In the sense like either maintenance therapy can be zinc or maybe a low dose chelation. So these are things you are going to follow. Either zinc or probably a low dose chelation. Both can be choices. Just hold on. Okay, all right. So these are the important things that you need to know about Wilson disease. Remember, initially the urinary copper excretion will be very high because they drain the body out of copper and excrete in the urine, the chelating agents. And over a period of time, it will become less than 200, and that's going to be the ultimate target. And the total, the non-cellular plasmin bound copper, that is, a free copper should be less than 15 microns per deciliter, and the patient should have a normal LFT. Usually, the targets will be achieved in a period of 6 months to 5 years, and that's going to be the total duration of chelation. Once you have achieved all these targets, then probably you can put the patient on maintenance therapy, which is going to be either zinc or going to be a low dose chelative therapy. So this completes the discussion on Wilson disease. So if you have any doubts on Wilson disease, you can ask, or if you don't have any doubts, we can proceed further to hemochromatosis. Clear? Do you understand Wilson disease, by the way? So whatever we discussed. Okay, so what we have discussed is first is going to be the epidemiology, then chromosome pathophysiology, then we have discussed on the clinical features, the hepatic, neurologic, psychiatric, and ocular presentations, including renal presentations and cardiac presentations we have discussed. Then we have discussed on the diagnostic standpoints, what is the algorithm for diagnosis of Wilson disease. Then we have discussed on the treatment part, prognostic index and diagnostic scoring. And of course, we have discussed on the treatment part as well, when to use chelation, when not to use chelation. And what is the best therapy? Of course, it's chelation. Zinc is not at all a best therapy, to be honest. And of course, next thing what you need to know is what are the targets to be achieved and when to put the patients on maintenance therapy once you achieve the target. Okay. Next is the hemochromatosis. This is the next disorder that we're going to discuss, hemochromatosis. There are many forms of hemochromatosis. We know that. So one is going to be the primary hemochromatosis, or we can call it as hereditary hemochromatosis. And second is going to be the secondary hemochromatosis. Secondary hemochromatosis is due to secondary iron overload. In the sense, usual cause will be multiple transfusions. So transfusional iron overload. Second is going to be ineffective erythropoiesis. The best examples where repeated transfusions will cause iron overload is going to happen in the setting of probably hemoglobinopathies, like probably thalassemia. So that's where it's going to happen. Point number one. Or probably in patients with myelodysplastic syndrome. This is another situation where you're going to have multiple transfusions, repeat transfusions again and again. So whenever you do repeated transfusions, you might develop with a secondary iron overload and hemochromatosis. Secondary hemochromatosis. And next thing what you need to know is ineffective erythropoiesis, as I told you. Ineffective erythropoiesis. We have discussed this in premium lectures, I guess. In the hematology section, we have discussed this already. In thalassemia, the reason for iron overload is two things. One is due to transfusion, and second is due to ineffective erythropoiesis itself. So ineffective erythropoiesis, the best examples will be thalassemia. Probably you can think about sickle cell disease, or probably some conditions like sideroblastic anemia, where you can have ineffective erythropoiesis. Because of that, you might have an iron overload. And third is excessive alcohol consumption, which can produce secondary iron overload. Because alcohol is known to increase iron absorption. At the same time, alcohol can also produce sideroblastic anemia, because alcohol can derange the pyridoxine metabolism and so and so. So because of that, you can result in sideroblastic anemia and secondary iron overload. And alcohol directly can increase the absorption of iron, and that can also cause iron overload over a period of time. And any patients with chronic liver disease may have an iron overload, because liver is the one that handles iron efficiently. If the liver cannot handle iron efficiently, so there will be a lot of free iron, which can result in deposition of iron in other areas, and they can result in problems, chronic liver disease. And next is porphyrias. We know porphyrias, all porphyrias will result in increased hepatic iron overload. That's why porphyrias have a risk of developing hepatocellular cancer as well. The reason why porphyrias cause, we have discussed multiple times in the past. So you know that for producing hemoglobin, you need heme. At the same time, you need iron as well to produce hemoglobin. Suppose if you cannot produce heme, so that's what is happening in porphyrias. You will not be able to produce sufficient amount of heme, which means the iron is something that cannot be utilized here. Sorry, here it is globin, isn't it? Globin. So heme is basically going to come from two things. One is going to be the iron, and second is going to be the porphyrin ring. Both are going to produce heme. So in porphyrias, you cannot produce the porphyrin ring, which means the iron will be underutilized here. So there will be excessive spillage of iron because you cannot produce sufficient porphyrin rings to produce heme. So that is the reason why this iron might get deposited in the organs, resulting in iron overload. So that is another reason why you get second iron overload. One of the important reasons porphyria. Remember, porphyrias also carries an increased risk of developing hepatocellular cancer. For any porphyria, for that matter, has increased risk of developing hepatocellular cancer. And what about hereditary hemochromatosis? There are many different types of hereditary hemochromatosis. In that only one thing I'm going to discuss, but nevertheless, you have many different types. You have type 1, you have type 2A, then you have type 2B, then you have type 3, then you have type 4. Basically, you have 4 types. In the type 2 has 2A and 2B. Almost all are inherited as autosomal recessive inheritance, except one, which is the last type, that is autosomal dominant. If you ask, the gene that is defective is the most common gene that is defective in hereditary hemochromatosis, that is HFE gene. And second one is HJV, that is hemojuvelin gene. And third one is HAMP. This is the one that produces hepcidin. HAMP is the one that produces hepcidin molecule. So that can be defective. And next, TFR, transferrin receptor, can be defective. Or next one, there is something called SLC40A1. So this also can be defective. This is a protein that can be defective. So what is a protein that is coded by HFE? HFE codes for HFE protein. This is the gene we are talking about. This is the protein we are talking about. HFE codes for HFE protein. And HJV codes for HJV, hemojuvelin protein. And HAMP codes, as I told you already, it codes for hepcidin protein. And transferrin receptor codes, TFR codes for transferrin receptor type 2 protein. And SLC40A1 codes for ferroportin. So, we have discussed all this about what is ferroportin and what is HFE, what is hepcidin, what is transferrin receptor. All these things have been discussed already, but just I'm telling the fact. So the rarest form is this fourth form only, which is the rarest form, and the most common form is going to be the HFE gene mutations. And HFE's gene mutations has 2 types. So one is this classic C282Y, which is the most common, 85%, and less common is H63D mutations, 15%, which is much, much less common. Remember, type 1 typically presents in adults. Type 2A presents in children, because you can remember the name hemojuvelin, so it presents typically in children. And type 2B, you can remember 2 presents in children, so 2 also, this also is going to present in children only. And type 3 will present in young adults, and type 4 come back to adults. So type 1 is the most common, that typically presents in adults. You can remember type 2 is the only thing that presents typically in children, hemojuvelin related mutations. And there are some variations in the distribution of copper as well. For example, if you take the first 3 types, 1, 2, and 3, the copper will be typically present in, typically seen in the periportal region of the hepatocytes, or probably in the central lobular distribution. So periportal is location is the place where you see maximum amount of copper. That is, not copper, iron. Because we are discussing about hemochromatosis. Maximum amount of iron is typically seen in the periportal region in types 1 to 3. But when you go for the type 4, the copper is typically not seen in the parenchyma of the liver. Instead, it will be seen more in the Kupffer cells. Of course, because this is a ferroportin defect. So because it's a ferroportin defect, the ferroportin is very, very important for transport of copper in the reticuloendothelial system. That is the reason why one of the important reticuloendothelial system cell within the liver is Kupffer cell. That is the reason why in ferroportin defects, that is SLC40A1 defects, the iron is predominantly seen in the Kupffer cells. So in the first 3 types, 1, 2, and 3, iron will be typically seen in the liver parenchyma, especially in the periportal region, then followed by the central lobular region. So 1, 2, and 3, periportal region. And in type 4, it's the Kupffer cells, which is going to have the maximum amount of iron. So which is very important. And also one of the important significant features of type 4 is the fact that it's the only type of hemochromatosis, hereditary form of hemochromatosis, that's going to be autosomal dominant inheritance. And of course, iron, the problem is the Fenton's reaction. Again, iron is a very important oxidative agent and it can oxidize anything. And there will be a free radical injury because of Fenton's reaction. And that's going to result in a lot of damage to the organs where it is going to get deposited. So what are the sequelae of excess iron, which means what is going to be the clinical features? So remember, the main organ that will be handling the iron is going to be the liver. So liver is the first organ to be affected and one of the most important organs to be affected, which can result in the development of cirrhosis and hepatocellular cancer over a period of time. And it can get deposited in some endocrine organs like pancreas, pituitary and all. In the pancreas, it will result in diabetes mellitus. At the same time, it can result in deposition in the skin that is called as, that can result in development of hyperpigmentation. And this has given the nomenclature called as bronze diabetes, we know that. And these three things is what we call as classical triad of hemochromatosis, which I have discussed multiple times in the past: cirrhosis, diabetes, and hyperpigmentation of the skin. So this is a classic triad, even though the classic triad is seen in less than 10 to 20% of the individuals. We know that. But liver is the most common organ to be affected due to iron overload, especially hereditary forms of hemochromatosis. It can get deposited in the pituitary and gonads as well. Because of that, it can result in hypogonadism. This hypogonadism can be of any type. If it's pituitary related problem, then it will be a hypogonadotropic hypogonadism. If it's a gonad related problem, then it will be a hypergonadotropic hypogonadism. Then apart from that, it can can deposit in the joints. Iron can get deposited in the joints, which can cause this typical hemochromatic arthropathy. And they will ask you which is the most common joints that will be affected, are the typical classic joints that will be affected in hemochromatosis, that is second and third MCP joints. Second and third metacarpophalangeal joints are the most common joints that are affected in hemochromatosis. And remember, usually hemochromatosis will result in chondrocalcinosis, and this chondrocalcinosis may be the reason for developing CPPD as well. In fact, we have discussed in rheumatology itself, hemochromatosis is one of the important risk factors for developing calcium pyrophosphate deposition disease, that is CPPD. And these patients also have increased risk of developing joint infections. Not only joint, increased risk of developing certain infections as well. I think in the premium sessions in hematology, I have discussed this. Certain chelating agents itself will increase the risk of infections. Similarly, increased iron in the body itself will increase the risk of certain infections like listeria. Second is Yersinia enterocolitica infection, because this is a siderophoric organism, which is an iron-loving organism. Then we have Vibrio vulnificus. This is also an iron-requiring organism. I can write Vibrio vulnificus. So clear? Iron generally promote listerial growth. Yersinia is also an iron-loving organism. And Vibrio is basically an iron-requiring organism. This Vibrio vulnificus. These are the three infections that are going to happen in increased incidence in patients who are having increased iron in the body, especially those who are suffering from hemochromatosis. But please understand the fact that hemochromatosis, especially hereditary forms per se, are extremely rare in India. It's very common in Caucasian population. If you go to Europe, or if you go to especially Northern Europe, UK, Scotland, Iceland, Greenland, Norway, Sweden, including France, Germany and all, such a common disease. Any patient who's coming with liver disorder, especially chronic hepatitis or an acute hepatitis, they do mandatory serum ferritin. And that's a very important test for them. But in India, it's a very, very rare disease. Even if I have not seen, during my post-graduation days, I tried to diagnose this hereditary forms of hemochromatosis, but I failed really. I thought it's hereditary hemochromatosis, but ultimately, it won't be hereditary hemochromatosis, it will be something else. That's because of excitement during that period. I try to diagnose hereditary hemochromatosis, but you can never find out in India. I don't think so. If anyone finds, you can present it in a paper. It's a very rare disease in India. You don't find hereditary hemochromatosis really. That's practicality. If somebody finds hereditary hemochromatosis, you cannot ask the pedigree analysis very properly. The reason is because either some of their ancestors would be of Caucasian descent, or there could be Anglo-Indian population, or probably they are bluffing anyone. It's very, very rare to have hereditary hemochromatosis without a Caucasian background. It's impossible. That's something you need to know. And the pathophysiology very simply. So, pathophysiology is quite easy. So we don't want to discuss that in detail. Let me tell you a quick pathophysiology of that. This is a hepatocyte and they can sense the circulating iron, of course. And the most important ways of sensing this ion is the transferrin receptor 2. I can write TFR2. The transferrin receptor type 2 is the one that senses ion in the hepatocyte. And once they sense ion, this will give signal to the HFE gene. And this HFE gene, through a cascade, it will give stimulus to the hemojuvelin. And further, it will give stimulus to the BMP6 receptor, that is bone morphogenic protein 6 receptor. And once this BMP6 receptor is activated, they will activate a pathway called as SMAD pathway. So this SMAD pathway, especially SMAD4, is the typical molecule that we're going to discuss. This SMAD4 is going to bind to the certain domains in the DNA, and they will activate a very important gene called as HAMP gene that will be activated. Upon activation of HAMP gene, they're going to produce hepcidin, of course. And this hepcidin is considered to be a central molecule of iron regulation in the body. And this hepcidin, of course, is going to have multiple effects. The most important effect is going to be inhibition of ferroportin. Ferroportin is the portal for iron entry into the body. In the sense, like two ways of free iron formation in the body. One, it absorbs the dietary iron. For absorption of dietary iron, you need ferroportin. Even though DMT2, you have studied, is in the divalent metal transport. DMT is the one that is important for absorption from one side, from the luminal surface of the enterocyte. To push this ion into the other surface of the enterocyte, you need this ferroportin, which means ferroportin is important for absorption. At the same time, you have the senescent RBCs, which are actually swallowed and destroyed by the reticular endothelial system, like macrophages and other forms of reticular endothelial system. That again, through ferroportin only, they're going to release iron. So, and this ferroportin will be basically blocked by hepcidin. Hepcidin is the one that's going to block this ferroportin. So, in the sense, like hepcidin is the one that actually tries to reduce the serum iron in response to sensing of iron. So, it's like a negative regulating thing. So, it's a negative feedback kind of an hormone. Like hepcidin can be regarded as a hormone as well. So, that's how it works. And the amount of hepcidin can be increased by multiple ways. So one way to increase is inflammation. Inflammation increases hepcidin, which means hepcidin, you can think it as a positive acute phase reactant as well. So that is why whenever there is an inflammation, you will have increased ferritin. At the same time, you have increased hepcidin as well. And that's why anemia of chronic disease is completely different from iron deficiency. In iron deficiency anemia, you have low ferritin and of course an undetectable hepcidin in iron deficiency. Because in a true iron deficiency, your amount of iron will be low in the body. So that is why hepcidin levels will be undetectable. But in patients with anemia of chronic disease, because of inflammation-related anemia, you will be having high hepcidin and you will be having high ferritin as well, because both hepcidin as well as ferritin are considered to be acute phase reactants in that perspective. Clear? So hepcidin is a positive acute phase reactant. So that is the reason whenever you have a problem, for example, let us assume you have a problem in HFE, that is HFE gene. So if you have a problem in HFE gene, your hepcidin levels will be very, very low, which means this entire cascade will be abnormal in the sense like they cannot stimulate hemojuvelin, they cannot stimulate SMAD, they cannot stimulate HAMP gene, so the hepcidin production will be low. So if at all the hepcidin production is low, now it's like the sensing capacity is lost. They cannot sense the serum ion anymore, and they will be absorbing the ion in an unregulated fashion. So there will be unregulated ion absorption in the intestine. Because of unregulated ion absorption, the serum ion will increase and the free ion in the body will increase, and they will start depositing in the organs as well, causing damage. And this increased ion cannot be sensed because HFE gene is a defect. So they will be persistently having low hepcidin and they will be having unregulated ion absorption. Because of that, this is going to result in development of ion overload and subsequently results in hemochromatosis. And that is the problem here. So this is this, pathophysiology in a nutshell. So either HFE gene defect or probably HJV gene defect or probably HAM gene defect, all these things will result in hepcidin deficiency. And because of hepcidin deficiency, you might result in increased ion absorption, unregulated ion absorption. Because of that, you might result in development of secondary ion overload. Remember, ferroportin defects typically result in different kind of a problem in the sense like they cannot eliminate ion from the reticular endothelial system. In the sense like the reticular endothelial system ion will increase, and that is why I told you in ferroportin defects, in type 4 hemochromatosis, you're basically going to have ion deposition in the reticular endothelial system, that is Kupffer cells, and that is going to damage the liver, because Kupffer cell activation will result in cirrhosis and subsequently hepatocellular cancer as well. So we have discussed that already. So type 4 is a little different, but type 1, type 2, and type 3 are basically straightforward, which is easy to understand. So this is a pathophysiology of hereditary hemochromatosis in a nutshell. As we have discussed, let us see some of the important clinical features here. As I've told you, patients can be asymptomatic in the sense like they will come with just LFT abnormalities. This is one of the most common presentation. In the sense like most of the hereditary hemochromatosis patients will be coming in an asymptomatic fashion. In the sense like just with an asymptomatic LFT abnormality. OTPT might be elevated. So that is one way they can present. Symptomatic presentations are quite rare. If they come with symptoms, the most common symptom is going to be fatigue. Fatigue is the most common symptom of many other disorders, like even SLE also, fatigue is the most common symptom usually at the time of presentation. So fatigue is the most common symptom for hereditary hemochromatosis patients or any hemochromatosis as well. And this is followed by hyperpigmentation. And this is followed by arthralgia. Arthralgia is quite common, typically affecting the second and third intercostal joints. Then fourth is going to be the impotence. And they can develop diabetes mellitus. They can develop cardiomyopathy over a period of time. And they can develop cirrhosis and hepatocellular failure as well. I mean, hepatocellular cancer as well over a period of time. So these are basically regarded as complications of hemochromatosis. And one of the important complication that you need to know is cirrhosis and hepatocellular cancer. Even though they can produce cardiomyopathy, cardiomyopathy can be of any type. It means it can be of hypertrophic type, or it can be of restrictive type, or it can be of dilated type also. It can produce any form of cardiomyopathy. But in exam, it's better to answer restrictive type, even though it can produce dilated type of cardiomyopathy. Hypertrophic is the rarest form of cardiomyopathy. All these three types of cardiomyopathy are described in literature: hypertrophic, restrictive, as well as dilated. But in exam, if you want to go, you can go for restrictive type. But in reality, which is, I mean, these common things are not mentioned in literature. That's why. But there are some small trials which tell restrictive is more compared to dilated. But in no textbook really tells which is more common, restrictive or dilated. But in exam, I would answer if they ask. I don't think they will ask, but if they ask, I'll go for restrictive. Dilated is little less common, but they can produce dilated as well as restricted form of cardiomyopathy. Least common form, it's very clear it is hypertrophic form. Then coming to the investigations and diagnose, how to diagnose based on your workup. So investigation wise, you have a screening test. The first screening test or the first test to be done in patients with suspected hemochromatosis, transferrin saturation. TSAT is the first test. It's going to be the most sensitive and it's going to be screening test. For all practical purposes, we often combine with serum ferritin because ferritin is not that expensive test. It's very commonly done. So whenever you do a TSAT, you also do a ferritin. For all practical purposes, you are going to do TSAT and ferritin together. It's not that you're going to do only TSAT for the first time, or only TSAT you're not going to perform. You're going to do along with ferritin only. So let us see an algorithm. Suppose a patient is having a suspected iron overload. What you will do? The patient is having a suspect iron overload. So you are going to do TSAT and ferritin together tandemly. I'm not telling you will do only TSAT, like how I told for Wilson. This is the same pattern I'm going to use. So if the TSAT is less than 45%, or the TSAT is more than 45%. If the TSAT less than 40%, it is definitely not hemochromatosis. It's not hereditary hemochromatosis for sure. You can rule out because it's considered to be extremely sensitive. Then you can see ferritin. If the ferritin is also normal, then of course it's a normal person. I mean, I'll not call normal patient, I'll call normal person because this is completely normal. So the ferritin levels are increased. In this condition, think about other causes of elevated ferritin. Other cause of increased ferritin, probably it might be due to some inflammation, because in inflammation, the TSAT levels will be low. That's something we have studied. It's a common thing with iron deficiency. Both iron deficiency anemia as well as anemia of Crohn's will have a low transferrin saturation, but they'll be having a high ferritin. So yeah, think about other causes like inflammation. If the TSAT is more than 45%, then in that setting, you can think about a likely iron overload. So now you can see serum ferritin here in this perspective. Serum ferritin levels are low, or probably serum ferritin levels are normal. I'm not calling low here because low serum ferritin goes towards an iron deficiency anemia, which I'm not going to do. I'm not going to discuss about that. So serum ferritin is normal, which means here you're just going to do a close follow because these patients are prone for iron deficiency. I mean, iron overload over a period of time. The serum ferritin is increased, then definitely this patient is having a iron overload for sure. So remember, increased transferrin saturation and increased serum ferritin will only tell that the patient is having a likely iron overload. That will not tell you the cause. Then further you need to evaluate for the cause. So how will you tell that the patient is having hereditary hemochromatosis? For that, the best test, if at all somebody asks you, answer will be genetic testing. Of course, it will tell you the type as well as whatever you want you can get out of this genetic test, which means classically you will be looking for the homozygosity of that C282Y and H63D of the HFE gene. That's what you're going to find. Or alternatively, you can do a liver biopsy as well. Once again, liver biopsy is not going to suggest you, like hereditary hemochromatosis, because if you want to use the term hereditary hemochromatosis, you need to do a genetic testing. That's the only way. But liver biopsy can be used as an adjunctive test. Liver biopsy is considered to be the traditional gold standard. And you know what is the stain that we are going to do in liver biopsy for staining iron? So let me show you this picture. So you will be able to tell. What is the stain basically and what you're seeing here? So whatever that is shown in this blue granules, like this blue granules inside the hepatocyte are basically the iron deposition. So what is the stain that is used? It's a very common thing. I mean, I just want to know whether you're attending or not. What is the stain that is used? So this is Pearl's Prussian blue, or simply called as Pearl stain. So it's otherwise called as Pearl's Prussian blue, or simply Pearl stain. So that's what I'm going to use for staining iron. So this is a liver biopsy specimen that is stained with Pearl's Prussian blue, and you can see these iron granules in the liver biopsy. Clear? And there is a lot of grading which is not good to discuss right now, which is beyond the scope of the current discussion. And when you do liver biopsy is not mandatory for diagnosis, but it is important for prognostication as well. So to see the extent of liver damage. So for that, you need liver biopsy. It's not only for diagnosis, you need genetic testing. But to see the extent of liver damage, you need liver biopsy as well. So when will you do? What are the main indications for doing liver biopsy? Number one, elevated liver enzymes, ALT, AST elevated. Second, serum ferritin, more than 1000. Serum ferritin more than 1000. These patients are highly prone for developing cirrhosis and hepatocellular cancer over a period of time. And that is the reason why liver biopsy is indicated here. Remember, liver biopsy more than more than it is used for diagnostic purpose, it will be more used for prognostication. In the sense, like, to see the extent of liver damage, amount of cirrhosis or a hidden cirrhosis in the liver, you need a liver biopsy in this setting. Because whenever ferritin is more than 1000, and if AST, ALT are elevated, it means definitely there is ongoing damage, and the patient can have cirrhosis. You don't know. So that is the reason why you need a liver biopsy. Liver biopsy is more prognostic in this particular situation. So this is the most important thing to know. And apart from that, you can do MRI. MRI is one of the non-invasive methods of quantifying iron. If they ask you the best non-invasive ways to quantify iron or liver iron, or the best non-invasive test to quantify hepatic iron, MRI is going to be the gold standard. One more advantage of MRI is the fact it can actually assess cardiac as well as hepatic iron. It is not going to only assess the liver iron, it's also going to assess the cardiac iron as well. So both cardiac iron overload as well as liver iron overload can be diagnosed with MRI testing. And based on liver biopsy, you can tell the severity depending on amount of iron. So you can divide into mild, moderate, and severe. So mild in the range of 71 to 98 microgram per gram of dry weight, or micromole per gram of dry weight, and moderate in the range of 99 to 200 micromole per gram of dry weight, and severe means more than 200 micromoles per gram of dry weight. Whenever hepatic iron concentration is more than 80, you can think about iron overload. Normal hepatic iron will be somewhere around less than 40 or less than 35. That will be normal hepatic iron. But if it's more than 70 or more than 80, definitely you can think about iron overload. Mild means 70 to 98, moderate means 99 to 200, severe means it's going to be more than 200. Based on certain algorithms, you can even tell how much hepatic iron is there in this particular patient. Then coming to the treatment of iron overload, as well as treatment of hereditary hemochromatosis is concerned. I mean, remember, first of all, you need to know how you treat HHC as well as secondary iron overload. So patients who are asymptomatic, plus if they're having serum ferritin less than 500, you just need an annual follow. That's all. Just annual follow-up is enough. If the patient is asymptomatic and having a serum ferritin of less than 500. Suppose the patient is symptomatic, that's all, or having a serum ferritin of more than 500, then definitely you need to treat this patient, and the treatment of choice is phlebotomy. Phlebotomy is the best treatment for this patient. Chelation is not a very good option. Phlebotomy is the best option. Plus, at the same time, you need to give a complete, like dietary advice. So to reduce the dietary iron intake. This is very, very important, because I told you in the problem in any form of hereditary hemochromatosis, the excessive absorption of iron from the intestine because of low hepcidin. So they cannot afford to take any substance which has increased iron. So you should always tell a strict dietary advice to reduce the intake of dietary iron. Suppose if the patient is not tolerating phlebotomy, or the phlebotomy is contraindicated, then second line option will be chelating agents. Chelators. There are many different types of chelators, right from deferoxamine to deferoxamine. You have different types of iron chelators are there. But typically only if the phlebotomy is contraindicated or the phlebotomy is intolerable, then in that setting you can go for chelators. But apart from that, phlebotomy is going to be the standard therapy of choice. Can you tell what is the contraindication of phlebotomy? Can anyone tell what is going to be the contraindication of phlebotomy? Contraindication of phlebotomy. So what makes phlebotomy as a contraindication? What makes phlebotomy a contraindication? Where you should not do phlebotomy or where you cannot do phlebotomy? Not really cellulitis. The most important contraindication is going to be the anemia. Anemia is a very important contraindication for doing a phlebotomy. Already the patient is anemic. How can you remove blood? You can't. So that's why anemia is a contraindication. So whenever anemia is there, in that setting, you can go for chelating agents. But if the patient is not having anemia, then any iron overload, phlebotomy is the best option. So patients are having, that is the reason why patients are having thalassemia. You don't really give phlebotomy. The reason why you don't give phlebotomy in thalassemia patients is because they're already anemic, severely anemic. You can't do phlebotomy there. In that setting, for transfusion-related iron overload state, chelating agents are the best choice. So, but remember, secondary means in exam, usually you encounter this thalassemia or probably myelodysplastic syndrome. So where you're going to use chelators as a first choice. Phlebotomy is contraindicated here because the patient is thalassemic and they will have severe anemia, and you cannot give phlebotomy, and chelators are the best choice in this particular patient. Clear? So then you can see the resolution markers as well. So what is the amount of phlebotomy you should do, and all these things beyond the scope, but still let me tell you how much of phlebotomy should be done. Typically we do initially, not later. Initially we remove 1 to 2 sittings per week of phlebotomy. Each sitting will remove approximately 500 ml of blood. 500 ml of blood will be removed per session in each sitting. So typically in the early stages, we'll do 1 to 2 sittings per week. But later on, depending on serum ferritin levels, you can adjust your number of phlebotomies over a period of time. But initially, whenever the serum ferritin is very high, like more than 1000, that will be the usual case in the setting of hereditary hemochromatosis. In that setting, probably you can try 1 to 2 sittings per week. Each sitting will remove 500 ml of blood approximately. So you are going to do this till you reach a particular target. What is the target? Of course, the serum ferritin is going to serve as a target as well. It should be in the range of 50 to 100, which is a normal serum ferritin, 50 to 100 nanograms per deciliter. So if you reach this 50 to 100 nanograms per deciliter range of serum ferritin, normal is somewhere around 10 to 200. So if you reach this 50 to 100, so that's a normal ferritin, and that's going to be the target. Clear? So once you have achieved this target, then you can go for maintenance phlebotomy. So maintenance phlebotomy, just one sitting every probably 3 months. So typically every 2 to 4 months. So, but in general, we advise the patient to come for phlebotomy every 3 months. So this is the usual maintenance dose of phlebotomy. So initially you start with 1 to 2 sittings per week till you reach a target serum ferritin of 50 to 100. After that, you can go for maintenance phlebotomy. That is one sitting every 3 months, or ideally 2 to 4 months. That's the ideal thing. So what is the, outcomes? So once you do phlebotomy and you remove iron periodically, what are going to be the outcomes? Outcomes, which means there is something called resolution of certain symptoms, and there are certain symptoms which will not resolve, no resolution. And this is something which will be asked in exam. So even if you do a phlebotomy in a patient with hemochromatosis, what are the symptoms that do not resolve? Which means what are things that are irreversible? That's what I'm asking. One is hypogonadism, very, very important. Hypogonadism is something that cannot be reversed with any kind of treatment in hereditary hemochromatosis. And second is arthropathy. These are the two things that are routinely asked in many entrance exams. Around the world, everywhere they will ask, especially go for USMLE or even PLAB exams. This is something that's one of the 100% questions. What are things that will not resolve with phlebotomy? Hypogonadism and arthropathy. Probably you can think about cirrhosis and HCC. Remember, this is something that is already known. Once the patient goes to cirrhosis, you cannot reverse. It's an irreversible stage. We know that. So that is something not going to be an exam question. So the exam question is going to be on hypogonadism and arthropathy, which cannot be reversed, even if you do phlebotomy or any other modality of iron iron removal state. Resolution will happen in cardiac function. Cardiomyopathy is something that responds excellently with phlebotomy and removal of iron from the body. So cardiomyopathy is very, very important, which responds to iron removal and phlebotomy. And second is fatigue, which is one of the very common symptoms, as I told you, that will resolve over a period of time. And diabetes is something that can improve. And skin hyperpigmentation also improves to a great value. Skin hyperpigmentation. And subjectively, hepatomegaly, which is commonly seen in many hemochromatosis patients, might improve over a period of time. Remember, if the patient has gone for cirrhosis, then it may not improve. But if the patient is not having cirrhosis but having only hepatomegaly, it might improve over a period of time. But the most important point here is the fact that cardiomyopathy and diabetes will resolve with treatment by phlebotomy. So with treatment, cardiomyopathy and diabetes will resolve, but hypogonadism and arthropathy will not resolve usually. So contraindication of phlebotomy, as I told you, the most important contraindication is going to be anemia. Second is, of course, poor vascular access. This is not common nowadays. If you don't have vascular access, you cannot remove the blood. So very simple contraindication. Anemia is the most important and the most important clinical contraindication, if you see. Most clinically relevant contraindication. And next is heart failure. Because heart failure patients will not tolerate to removal of blood and anemia subsequently. So heart failure, anemia, and poor vascular access, three contraindications, but anemia is going to be the most important contraindication of all. Fine. So this is all about hereditary hemochromatosis. So what all we have discussed in hemochromatosis, we have discussed the difference between primary and secondary forms of hemochromatosis, and the 4 gene defects we have discussed already, and what are the complications due to hemochromatosis, and what is the pathophysiology. The first 3 types are due to low hepcidin, directly or indirectly, like probably HFE, HJV, or AMP gene mutations. Fourth one is a little different, autosomal dominant due to ferroportin defect, and that will result in poor release of iron from reticuloendothelial system. So that will be a little different accumulation of iron in the RES, and especially Kupffer cells in the liver. All other 3 types will have increased iron accumulation in the hepatocyte parenchyma. And clinical feature wise, most of them will present asymptomatically with incidental LFT abnormality. Few can be symptomatic. Most common is fatigue, and we have seen a variety of other symptoms. How to diagnose? The first and the screening test is TSAT, usually done along with ferritin. And if you have high ferritin, high TSAT, it's iron overload, but you need to find out the cause. The best is genetic testing for that. And liver biopsy, more than diagnosing, it's used for prognostication, especially to see the amount of damage done by the excess iron. Indications are serum ferritin more than 1000 plus, increased AST or ALT. MRI is the best non-invasive test which can assess both liver and hepatic iron both. The stain used for staining iron in the liver is pulse Prussian blue. And treatment-wise, secondary iron overload, best choice is chelators, because most of them will be due to anemia and transfer-related iron overload. And for primary hereditary forms of hemochromatosis, asymptomatic and serum ferritin less than 500, no treatment. Symptomatic patients need treatment. The best treatment is phlebotomy. And 3 contraindications you need to know. Most important is anemia, then heart failure, and poor vascular access. Usually done at 1 to 2 sittings per week, removing 500 ml of blood per sitting till you reach the target ferritin of 50 to 100. After that, you go for maintenance phlebotomy, which is going to be approximately one sitting in every 3 months, ideally 2 to 4 months. Outcome wise, hypogonadism and arthropathy will not resolve with phlebotomy, whereas cardiomyopathy and diabetes will resolve with phlebotomy. Do you understand this? So we can move on to the next one. That is alpha-1 antitrypsin deficiency. Cool. We have alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency. As far as alpha-1 antitrypsin deficiency are concerned, typically, like this is a disease that is codominant inheritance followed by autosomal recessive. But remember, in exam, this is something which is very important. So this is not autosomal dominant or not autosomal recessive. It is autosomal codominant. It's a codominant inheritance, kind of pattern of inheritance. And the gene defect, defective gene, the defective gene is something called as SERPINA1. It's a protease, SERPINA1, which is present in chromosome number 14. You can remember, Wilson disease and alpha-1 antitrypsin deficiency are next to each other. In the sense, Wilson disease is chromosome number 13 and alpha-1 antitrypsin is chromosome number 14. Both are metabolic liver disease and next door neighbors, 13 and 14. So SERPINA1 is present in chromosome number 14, and that is the defect here. And remember, synthesis of alpha-1 antitrypsin synthesis. They ask you where it happens in the liver. Liver is the place where you have alpha-1 antitrypsin synthesis going on. But it's going to affect the lung. So that is the irony here. But nevertheless, you have a lot of allelic variations are there. But whenever you have an alpha-1 antitrypsin deficiency, it can affect two organs. The most common organ affected is the lung. Lung is the most common organ that is affected in reality. Liver is not the common organ. Liver sometimes can be affected, sometimes may not be affected. So what is the reason for lung? The reason for lung problem. Lung means you are going to develop emphysema over a period of time. Emphysema. And the type of emphysema you develop with alpha-1 antitrypsin deficiency is pan-ascendant type of emphysema, not centrilobular type, which is seen in smoking patients. And typically it's going to affect the lower lobes. Whereas smoking-related emphysema will be centrilobular and will be affecting predominantly the upper lobes. But emphysema due to alpha-1 antitrypsin deficiency will be affecting the lower lobes and will be of pan-ascendant type. Entire acini will be affected. And the reason, the pathophysiology behind emphysema in patients with alpha-1 antitrypsin deficiency is the actual deficiency. Actual deficiency of alpha-1 antitrypsin is going to cause emphysema here. So you always have a balance between protease and antiproteases. Both have to be in balance. Right? One of the important antiproteases is alpha-1 antitrypsin. Suppose if alpha-1 antitrypsin levels are low, what happens? Your protease levels will be very high and antiprotease levels will be very low. So this too much of protease, especially proteases typically come from neutrophils. So this proteases might damage the elastin, which can subsequently result in hyperinflation and emphysema. So that is the idea here. So the problem here is very simple. It's the actual deficiency of alpha-1 antitrypsin that is going to cause emphysema, lung damage. But liver damage is quite different. Like liver damage is not due to alpha-1 antitrypsin deficiency. Here, the reason here, they might develop anything. They might develop chronic liver disease. They might develop cirrhosis over a period of time, which might further result in HCC. HCC is quite rare in alpha-1 antitrypsin, but nevertheless, it can result, theoretically speaking. So cirrhosis and CLD are real-time threats. But remember, the pathophysiology of developing hepatitis and liver problems in patients with alpha-1 antitrypsin is not the actual deficiency. It is actually the impaired secretion. Impaired secretion of alpha-1 antitrypsin by the hepatocytes. If they do not secrete alpha-1, which means here the alpha-1 antitrypsin is produced normally. To get a liver damage, first of all, you need to produce alpha-1 antitrypsin properly, and the problem should be impaired secretion. So if the patient is having impaired secretion but an okay production, then in that setting you might result in accumulation of this alpha-1 antitrypsin within the hepatocyte, which might damage the hepatocyte, resulting in development of cirrhosis and liver disease over a period of time. So that is why you need to know about the allelic variations. So first of all, let us talk about something called as an M allele. So let us see the allele and what will happen to the plasma level if you have that particular allele, and whether you'll have a lung disease or whether you have a liver disease or not. That's what we're going to see. The first allelic type is the M type, which is a normal allele. M is supposed to be the normal allele, which means the plasma levels are going to be normal with if you have a M allele. Lung disease definitely no, liver disease no, because it's a normal allele. And then you have a Z allele. Z allele is a defective allele, which means Z is the one that is going to produce the intracellular accumulation of alpha antitrypsin within the hepatocyte. In the sense, Z is typically going to result in OK production, but poor secretion of alpha antitrypsin, so it will accumulate within the liver. So in the sense, like the plasma levels will be reduced because they cannot secrete this alpha antitrypsin properly. And lung disease definitely yes, and liver disease definitely yes. There's no doubt about that. If you have a Z1, then there is something called as a S phenotype. If you have a S phenotype, there will be intracellular degradation of alpha antitrypsin, in the sense like they are produced properly. They can be secreted, not a problem, but due to unknown reasons, the secreted alpha antitrypsin is going to be degraded within the hepatocyte. Probably defective alpha antitrypsin. That's why they are degraded within the hepatocyte. In this setting, the plasma levels will be reduced for sure. And lung disease will be there here because there will be deficiency, but there won't be any liver disease, of course, because there is no accumulation, it's only degradation. Then you have something called a null phenotype. It's called null phenotype, which means there will be absolutely no synthesis of alpha antitrypsin. Here, typically speaking, there will be no alpha antitrypsin in the blood at all. And because of no alpha antitrypsin, because of deficiency, there will be lung disease here. But there won't be liver disease because there's no synthesis. So only accumulation will cause problems. If there's no synthesis, you cannot get liver disease here. So there's no liver disease again here. There is another form. This is a completely different form. There is a F form is there. So this is due to impaired binding with neutrophil elastase. Impaired binding with protease. Remember, anti-proteases should bind with proteases to neutralize them. So if they do not bind properly, once again, it's a functional defect. That's why it's called F. It's a functional defect. It's not a qualitative defect. It's not a quantitative defect. It's a qualitative defect. They cannot bind with the neutrophil elastase, which means they cannot bind with the antiprotease. Because of that, the levels may be normal, but they will be having lung disease, but they won't have liver disease because again here the secretion is normal. The problem is a functional defect. So if you see, there is only one allelic type that is going to result in liver disease, and that is the Z phenotype. So only Z phenotype will produce liver disease. Almost everything will produce lung disease. Every single phenotype will produce lung disease, but only Z allele or that Z phenotype is the one that is going to produce liver disease. So that is something which has to be known, and that's multiple times asked question in exam. And as far as the lung disease is concerned, you will result in moderate kind of emphysema in Z phenotype, very, very mild disease in the setting of S phenotype, and very severe disease in the setting of null phenotype, which means there is absolutely no alpha antitrypsin, so it will result in a very severe emphysema at a very early age. And here the severity is variable, which means the most severest form of emphysema will happen in null phenotype only, and the liver disease will happen only in Z phenotype. These are the two take-home points. Severest form of emphysema in null phenotype or a null allele, and in a liver disease will happen only in Z allele or Z phenotype. Remember, this is really, really important. Based on that, they will give some combinations, some genotypes as well. Based on this, they will be giving some combination and genotypes as well. So what are the combinations that you need to know? The first combination is called as PIMM. So PI stands for Pittsburgh here. So based on that, I mean, that's the terminology given. PIMM is there. So you know, M means both stands for normal. So we can put alpha antitrypsin levels in the plasma considered to be normal. Normal range is somewhere around 150 to 350 milligrams per deciliter. Clear? And intracellular accumulation will be there or not? Let us see. Intracellular accumulation will be there or not? So thereby liver disease will be there or not? Lung disease will be there or not? Intracellular accumulation definitely no. Liver disease no. Lung disease no, because this is a normal phenotype, normal genotype. So then we have PIMS is there. So here one is normal. I mean, because both are, I mean, one is got, I mean, why I'm telling two is because each allele is inherited from one particular parent. Father will give one, mother will give one. If both gives normal alleles, then absolutely normal person. If one is abnormal, one is of S type. So in that setting, it will be near normal because one is completely normal, one is of mild problem only, because here intracellular accumulation again is not happening, because the problem with S allele, I told you, it's intracellular degradation, not intracellular accumulation. So of course you are not going to get liver disease. And lung disease also is not a problem. Why? Because one allele is normal and that is enough to take care, and it will be a near normal alpha antitrypsin, so it will be of a silent type, so it can be deemed as a carrier, to be honest. And of course there's something called PISS is there. Again, these are called as carriers because there will be mild decline in alpha antitrypsin. In the sense, it will be in the range of 100 to 200 basically. Intracellular accumulation, once again, no. Lung disease and liver disease usually will not happen. And now, once again, these patients will act as carriers. And next, we have something called PIMZ is there. So once again, there will be a mild decline. Once again, the range will be in the 100 to 200. The problem with MZ is the fact that they are having a Z phenotype here. So there will be some intracellular accumulation, and there will be a liver disease, which will be of very, very mild type. Usually lung disease possible, theoretically speaking, but in general it is no. In general, they won't develop lung disease because the levels are very, very low. Very near normal range. Very mild decline in the alpha antitrypsin levels in the blood will be there. So possible lung disease, but in general they won't get. But liver disease definitely yes, but it will be very mild. Only elevation of transaminase will be there. And next phenotype is something called PISZ. Here moderate decline will be there, usually in the range of 45 to 80. That's the range. Intracellular accumulation definitely yes. And liver disease, yes, but it will be usually mild. Lung disease, surely yes, but it will be mild. And next we have something called PIZZ. ZZ, there will be a severe decline in alpha antitrypsin, usually in the range of 10 to 40 in general. Intracellular accumulation, yes, that is because of Z phenotype here. Both are Z, so definitely there will be intracellular accumulation. And liver disease, yes, very severe form of liver disease, and these patients are prone for developing cirrhosis as well. And there will be yes, and the disease will be usually severe in this setting. And next phenotype is PI null phenotype. Both are null. In this setting, there will be undetectable alpha antitrypsin levels, usually less than 10 milligrams per deciliter. And there will be no intracellular accumulation, which means there will be no liver disease, but there will be lung disease for sure, and it's the most severest form. Usually the most severest form is this null phenotype. As far as the lung disease is concerned, the most severest form as far as liver disease is concerned is the ZZ phenotype. ZZ phenotype will produce the most severe form of liver disease, and null phenotype will produce the most severe form of lung disease, which I have discussed already. And like this, we can write multiple genotypes, but these are the usual described phenotypes in Caucasian population. That is something which is important to know. But the final take-home point is whenever you have this Z allele, you will have liver disease. Whenever you have null, you have the severest form of lung disease. And almost every allele can produce lung disease. But apart from that, this this SZ, ZZ, and null phenotype is the one that's going to typically result in development of lung disease to a detectable range. And how will you know whether the patient is having alpha antitrypsin related emphysema or not? So whenever the patient is having a pan-acinar type of emphysema, you can think about alpha antitrypsin deficiency. Whenever the patient is having emphysema in an age of less than 45 years, very young emphysema, think about alpha antitrypsin deficiency. Third, whenever emphysema happens in a non-smoker at an early age, think about alpha antitrypsin deficiency. Whenever patient is having emphysema, along with that, the patient is having LFT abnormalities, which means lung and liver disease together, especially pan-acinar emphysema with the liver disease together, ALT, AST elevated, then in that setting you can think about alpha antitrypsin deficiency as a probable diagnosis. And if the patient is having predominant lower lobe emphysema, lower lobe involvement, think about alpha antitrypsin deficiency. And if the patient is having other associated problems, alpha antitrypsin deficiency has some associations with each other. One of the important association is going to be vaginous granulomatosis, especially ANCA-associated vasculitis. ANCA-associated vasculitis. This is something very important. This is something asked in previous exams as well. So you know why ANCA-associated vasculitis will happen? Because anti-neutrophil cytoplasmic antibodies is the key here. So remember, the neutrophilic cytoplasm will contain some proteases, especially neutrophil elastase is there. The problem is like this proteases should neutralize this cytoplasmic enzyme, that is elastase. If you don't have sufficient amount of anti-proteases, that is alpha antitrypsin, there will be too much of proteases, too much of neutrophil elastases, and they can develop antibodies against them. So that is the reason why you might result in ANCA-associated vasculitis like vaginous granulomatosis also, which is possible, which could be a question, probable question in your exam. And they can develop bronchiectasis because of emphysema over a period of time, and they can develop necrotizing paniculitis. Paniculitis means fat inflammation, especially in the thighs and the buttocks. They can develop necrotizing paniculitis. These are the usual clues towards the diagnosis of alpha-1 antitrypsin deficiency. The patient is having emphysema plus any one of this, like pan-Asana type, lower lobe involvement, associated left abnormality, non-smoker, age less than 45, and these kind of associations. If they have any of this, you can think about alpha-1 antitrypsin deficiency in exam. So investigation-wise, the best test, of course, they ask you is the genetic testing, which is the best test. You can do a genotyping, and that's going to be the best test, basically, genetic testing. And that's the most accurate test as well. And you can do serum protein electrophoresis, which can diagnose to an extent, but it's not specific or sensitive. So normally in a serum protein electrophoresis, you know what are the spikes you're going to see. You'll be seeing something like this. This is a normal serum protein electrophoresis. The bigger spike is, of course, the albumin. And after that, we have globulins. The final one, we have the gamma globulins. Then we have beta globulin. Then we have alpha-1 globulin. Then we have alpha-2 globulin. In patients with alpha-1 antitrypsin, especially if they have significant deficiency, they'll be having a small spike. Maybe a flattening of the spike like this. Apart from that, everything will be normal. Albumin, gamma globulin, beta globulin, alpha-2 globulin, all these things will be normal. Only this alpha-1 globulin spike will be little reduced. So that is suggestive of probable alpha-1 antitrypsin deficiency if you have appropriate clinical background. But the best test is always genotypic testing only, or genetic testing. So we can do liver biopsy. Liver biopsy is going to tell you the diagnosis only in Z phenotype. Like in other cases, it's very difficult to find out through liver biopsy. But in patients who are having Z phenotype, PIMZ or PISZ or PIZZ, so probably in this patients are having Z phenotype, you can see this intracellular accumulation of this alpha-1 antitrypsin. This intracellular accumulation of alpha-1 antitrypsin will be viewed as PAS positive but diastase resistant granules. Diastase resistant granules in the cytoplasm of the hepatocytes. But remember, this is valuable only if the patient is having Z phenotype. If the patient is not having Z phenotype, then this will not be that valuable, to be honest. So PAS positive diastase resistant granules inside the liver in a patient who's having Z phenotype, probably you can clinch the diagnosis of alpha-1 antitrypsin deficiency. Of Z phenotype. So other phenotypes, it's not reliable. But in patients who are having Z allele, so this will be there, that PAS positive diastase resistant granules. Let me show you an image so that you understand this better. I think this is an example here. I think this is of high memory, so that's why, like it's the large size file, that's why it's taking a little bit of time. It's not getting inserted, right? Yeah, got it. So these are the granules we are talking about. So these are the intracellular globules. These are PAS positive. The stain that you're seeing here is PAS. So PAS positive but diastase resistant globules inside the hepatocytes. You can get this in your exam as well. And this is an example of a fibrosis of the liver, so which I've shaded here. So that's a bridging fibrosis that you're seeing here. So which also tells that the patient is going for cirrhosis as well. And apart from that, therapy-wise, treatment of alpha-1 antitrypsin deficiency. So you're going to have supportive management only, like for lung and liver disease. For example, for COPD, you're going to give the same supportive management, and these patients should never smoke. Smoking is absolutely contraindicated. So already without smoking, they will develop emphysema. If they smoke, they're going to develop very accelerated emphysema. So they should never smoke, and they should stop smoking if they're already smoking. And you can try alpha-1 antitrypsin replacement which is commercially available but not very effective. So indication, if the patient is having very low levels less than 57 milligrams per deciliter, plus if the patient is having severe emphysema not improving with medical management, severe emphysema not responding to protein therapy, supportive management. So in this setting, probably you can think about alpha antitrypsin replacement. It's very costly, not that effective as well. That is why like usage should be more judicial and pertain to a particular patient. So in that setting, you can think about levels that are less than 57, plus the patient is having severe emphysema not responding medical management. Then in that setting, you can go for replacement therapy with alpha antitrypsin enzyme, and that will be a little effective. So that can improve the survival to some extent. Clear? But remember, giving alpha antitrypsin again will have effect only on lung disease, but it has no effect on liver disease, because lung disease only will improve to an extent by replacing the alpha antitrypsin. But liver disease, basically, we know it's due to intracellular accumulation of this alpha antitrypsin, which has literally no treatment apart from genetic therapy if it comes in the future. But you need to know that alpha antitrypsin will not have any effect on liver disease, but it can improve outcomes of lung disease to some small extent. So this is something which you need to know. Apart from that, this is the third metabolic liver disease which we have discussed, which is very easy. Let us recap: alpha antitrypsin deficiency, codominant followed by autosomal recessive, SERPINA1 gene defect, cousin to Wilson disease, that is chromosome number 14. Remember, pathology of lung disease is actual deficiency, but pathology of liver disease is actually intracellular accumulation, which is seen only in Z phenotype. So null phenotype produces the most severe form of emphysema. Z phenotype produces the liver disease usually. And we have different genotypes. Remember, Z, liver disease; null, severe emphysema. That's all. These are two things you need to know. Whenever you have emphysema plus pan-SNR type, or younger patient who's a non-smoker with LFT abnormality having low level of emphysema, you can think about alpha antitrypsin deficiency related emphysema for that matters. And at the same time, when the patient is having ANCA-associated this question might be coming in exam, like when the patient is having alpha antitrypsin deficiency, they are prone for developing vaginous granulomatous or any other ANCA-associated vasculitis as well. And the best test is always genetic testing. Serum protein electrophoresis might show reduced alpha peak if at all the patient is having significant deficiency, otherwise you will not pick up. Liver biopsy will show increased accumulation of alpha antitrypsin in the form of past positive diastase globules if the patient is of Z phenotype. Treatment is supportive. Alpha antitrypsin replacement can be tried if the patient is having severe deficiency with severe emphysema not responding to medical management. But remember, it has no impact on liver disease. It can improve lung disease to some small extent. So this is the final take-home point with regards to alpha antitrypsin deficiency. I think you understand this. With this, we'll take a break. Maybe I will start the class at 11 p.m. if at all you want. We'll be discussing on the liver tumors and hepatocellular cancer today. So maybe I'll start the class at 11 p.m. Thank you.